Hi, my name is Romina Mariano. I'm from South Africa. I'm 29 years old, I'm a clinician, and I'm very, very excited to be here. I'm currently doing my PhD at the University of Oxford under the supervision of Jackie Pallas, and my research interest is in the application of spinal cord imaging, conventional and quantitative and functional, and its applications in studying demyelination of the spinal cord in multiple sclerosis, aquaporin 4 disease, and in patients with MOG antibodies. Today, I'm going to be telling you about a cohort of patients who had onset myelitis with aquaporin 4 and MOG. So my abstract that I submitted and my poster, as you can see on the side, is to do with onset myelitis, so patients who had a spinal cord event in their first attack with aquaporin 4 antibodies and MOG antibodies. What we were interested in is looking at these two diseases that were previously thought to be part of MS and seeing what makes them different from MS and from each other. So we took patients from our Neuromyelitis Optica advisory service at the John Radcliffe in Oxford, and all those patients that had had a spinal cord event at their index presentation, we collected all their clinical data, their imaging at onset, and their outcomes. And firstly, we described the cohort and realized that in MOG antibody disease, people present often much younger, which plays a significant role in their recovery. And we also noticed that although at the onset their severity was quite the same, by the time you got to the end and were following them up at the recovery period, those with MOG, as is shown in the literature, recover much better. So we looked at their onset MRI scans to see if there were any significant differences we could find, and we found no difference in lesion length, or total lesion load, or the severity of the attacks. But we did notice that in MOG antibody disease, as you can see on the bottom left, they had more brain lesions, they had more episodes of conus lesions, and they also more commonly had more than one spinal lesion at their onset presentation. We then decided to look at what this might be able to tell us about the disease going forward. So on the left-hand side of the poster, you'll see graphs that relate to outcomes based on EDSS and the relapses that these patients might have. So the first graph is showing you essentially that although at the beginning of the disease course, all these patients have very similar EDSS, their onset attacks are similar, by the time you follow them up, those with aquaporin 4 are statistically way more likely to end with EDSS 6 and have persistent disability, whereas MOG patients tend to recover. And so for the aquaporin 4 group, we used EDSS 6 as the endpoint, and with MOG antibody disease, we used EDSS 4 as our disability endpoint because they tended not to reach EDSS 6. We then looked at what might be driving this. In the aquaporin 4 group, this seemed to be significantly driven purely by age, whereas in the MOG group, reaching EDSS 4 seemed to be associated with having a brainstem lesion at the same time that you presented with your transverse myelitis, as well as your outcomes of bladder and bowel being significantly associated with the presence of a conus lesion at onset. And these were very interesting findings about this very new antibody and gave us some idea of what we might be able to tell patients when they present about their outcomes. We then decided to look at relapses. First of all, although the number of patients that relapsed was quite similar in both groups, those with aquaporin 4 antibodies were a lot more likely to have multiple recurrent relapses. And more interesting was that the patients with MOG antibody tended to relapse with optic neuritis, and those with aquaporin 4 tended to relapse with transverse myelitis. So the disability accumulation with time is more significant in aquaporin 4 because they have multiple attacks of transverse myelitis, which is quite interesting looking at the two diseases being previously part of MS and now separating in these two very different ways. So this gives us a lot of interesting information about what we can tell patients when they arrive with their transverse myelitis, how they might do in the future, and also might inform treatment going forward. We'd love to increase our cohort to be able to say this with better data set, but for the moment we still think these are very interesting and topical results in this new age of neuroinflammation. So my interest in neurology goes back as far as I can remember. It's the reason that I went into medicine. Going forward, I'd like to finish my neurology training as well as my PhD in neuroscience. And I just think that particularly in MS, the exciting thing is that it's a field where we collaborate with people from all different backgrounds, different scientific backgrounds, different specialities, and it lies at the intersection of truly translational research, where what you see on scientific basic science posters really goes from bench to bedside, and that just makes it a really exciting field to be working in.